Good morning, everybody. My job is here to take you through the wide spectrum of this disease, ranging from a simple, typical CSCR to the most difficult ones like the exudative retinal detachment in a case of CSCR. So the usual patient is a male between 30 to 50 years and either type A personality, stress or corticosteroid use. And usually it's a unilateral blurring of vision or sentinel scotoma and vision between 6.6 to 6/60. And contrast sensitivity is often reduced even after the vision returns to the normal. And the usual fundus picture would be a young male with a localized serous detachment of the macula and a perifoveal point leak progressively increasing. And the 93% of the cases, it is an ink blot leak, which is a point leak which progressively increases. The 7% of the cases, the angiographically, it is a smokestack leak. And we know that these acute CSCR cases, within 3 months, around 60% of the patients spontaneously resolved. So that answers the previous question. When we look at the natural history, 1 week old CSCR, we are not justified in any sort of intervention. And persisting CSCR more than 4 months duration could be treated with a focal laser, 2 to 3 mild gray burns to the point leak seen on fluorescent angiography, and it hastens the recovery, though the final visual outcome may not be altered with respect to the natural history. So we start with the small atypia here, wherein you have a leak, point leak, subfoveal ink blot, but this cannot be treated with a conventional focal laser as in the typical case. So here either a low fluence PDT or subthreshold TTT would hasten the recovery within a month's time. Another atypical feature is when you have a subfoveal smokestack ink blot leak with a perifoveal smokestack leak. Again, this patient cannot be treated conventionally, and the post TTT picture shows only the persisting window defects and no leakage in the late phase. Another atypical variety of the disease would be a multifocal CSR, wherein here you have multiple point leaks progressively increasing subfoveally as well as perifoveally. So this patient also underwent the low fluence PDT and only the persisting window defects are there in the late phase. Another atypical variety would be a multiple PEDs in both the eyes, and actually these are not leaking PEDs. Here you see some of the leaking PEDs, and this needs to be addressed by either a focal laser or a PDT depending on the location of the leaks. So another atypical type of CSCR would be CSR with a subfoveal PED, subfoveal serous PED. For example, this patient with a large PED, with a leak from the edge of the PED, the conventional earlier notion was to treat this with a focal laser to the edge of the PED, but sometimes it can be disastrous like this, where you have a rip of the RPE with thick subretinal fibrin and fluid under the macula. Again, cases of subfoveal large PED with subretinal fluid leaking on fluorescent and FFA, post PDT resolution of the PED as well as the hyperfluorescence which was seen on the ICG angiography. Sometimes these renal patients on steroid induced CSCR post transplant, you can have these kind of leak where there is a leaking PED under the fovea, and even the OCT showing subfoveal PED. This patient actually underwent multiple sittings of TTT, not resolved, and pre-PDT also it is showing a leakage on fluorescent angiography under the fovea, and post low fluence PDT under the fovea shows disappearance of the PED as well as the fluid, and late phase of angiography showing only the window defects. So this is a case of 2 years old CSR which was treated. Here also another atypical feature, you don't see any point leak here, very non-specific leak because of the presence of fibrin under the fovea as well as the PED underneath. So it's not showing anything like a CSCR. So post subthreshold TTT showing some resolution and there is no fluid under the macula. Another atypical feature on OCT is late non-specific leakage on angiography. This is something called bridging tissue connecting the neurosensor retina to the underlying PED with a focal attachment. Few reports are studies shown that this attachment could be the area of micro rip in the RP causing the leak on angiography. Another typical variety is the inferior bullous RD with fibrin under the macula, kind of CSR, very little difficult to treat. Angiography shows multiple leaks and post TTT showing only the scarring and the RP degeneration following the treatment and resolution of the RD as well as the fibrin. Again, coming to another variety of CSR, it's chronic CSR more than 6 months duration. The acute to chronic progression is seen in around 16% of these eyes, and these patients are roughly older patients, more than 50 years, and with vision is presenting vision will be around 636, 660. RP degeneration, shallow fluid, and visual prognosis is guarded in these patients. Here we have a chronic CSR patient, something yellowish white material under the macula, resembling a CNVM with a late leakage, should not be confused for a CNVM. Post subthreshold TTT in this patient shows only the persisting window defects and the thick subretinal fibrin material under the fovea with a serous PD underneath that. Could think of a possibility of occult CNVM. Post subthreshold TTT, only the PED is remaining, fibrin and fluid has gone. Another patient with subretinal yellowish white material under the macula, multiple PED should give you a clue of chronic CSCR here. ICG angiography typically shows the late hyperfluorescence, fluid, PED and fibrin under the macula. Post TTT, only the PEDs remain, no fluid or fibrin. Montage picture showing a teardrop CSCR here with multiple areas of hyperfluorescence on ICG with a fluid under the fovea. So post treatment, that this point need not be treated in this patient. This is the active leak here. There is a hypofluorescence, hyperpermeability is reduced following the PDT here on ICG angiography. This is another patient, ICG angiography of an almost resolved CSCR with a PED. The other eye also shows hyperfluorescence on ICG angiography. So the question is whether to base it alone on the features of ICG. The question earlier raised, this answers the question. If you base your treatment on ICG, you have to treat all the hyperfluorescence, which would be over treatment. So recurrent CSCR, 15 to 50% it is seen in CSCR, and with recurrence, the final visual acuity as well as stereopsis and color vision comes down. So if you see such a patients with large cystoid spaces and few thin fluid under the thing, this is something called cystoid macular degeneration or CMD. This is a poor prognostic indicator. Even following PDT, I would not recommend PDT in this patient. So the other poor prognostic factors like CNVM, 4 to 5 years of duration, subretinal fibrosis are all poor prognostic indicators. Now the question is, you have a little older patient with suspected CSCR. So above 50 years, always keep in mind even a serous or hemorrhagic PED could be an occult CNVM. This is the typical serous PED, and if you have a notching of this PED or you have subretinal sub-RP hyperreflective echoes, you think of a fibrovascular PED, it will show on FFA early stippled hyperfluorescence with late non-specific leakage. Hot spot could be seen on ICG angiography or a plaque lesion. Another thing which you should not confuse is optic nerve head pit with serous macular detachment. 45% of these patients have serous macular detachment, though it starts with a schisis initially, and there will not be any point leakage on fluorescein angiography. So that is how you even if you miss a pit, it will not show any leak on in the retina, neurosensory retina. PCV, especially the exudative variety of the PCV with serous fluid and exudates, could be confusing, but ICG angiography will definitely show polyps with focal nodular hyperfluorescence with or without hypofluorescent halo, and branching vascular network also will be seen in PCV. So it is gold standard when you have a doubt in a little older patient with CSCR. Again, serous macular detachment in a patient, orangish red choroidal mass could be a circumscribed choroidal hemangioma with subretinal fluid. Here a smooth contoured with high internal reflectivity on ultrasound, and the multi-lake appearance, fine lacy in network of intrinsic vessel could prove the choroidal hemangioma if you have a doubt. Another is posterior flat and gray-white lesions with serous macular detachment. APM-PP should be a differentiating feature. with early hypofluorescence and late hyperfluorescence on FFA, and early and late hypofluorescence on ICG angiography. Multiple serous macular detachment should also can also be seen in Haradas variant of VKH. So here the multiple pinpoint fluorescence with late leakage, the starry sky appearance in the early AV phase should gather the diagnosis of Haradas disease when you have a patient with bilateral serous detachment. Again, the inferior serous RD with choroidal detachment could be a uveal effusion syndrome. This should not be confused with a serous RD in a atypical CSR. Scleral thickening more than 2 mm would be the diagnosis clinch here. Posterior scleritis can also sometimes produce a serous macular detachment, but obviously the optic disc swelling and choroidal folds and the ultrasound showing subtenonous fluid should be the diagnostic criteria. And sometimes you have a serous detachment with a yellowish white material again under the macula. We have to differentiate the inflammatory variety, that is chorioretinitis in such patients, because steroid is contraindicated in CSCR. So chorioretinitis with macular serous detachment, again chorioretinitis with macular serous detachment should not be confused with subretinal fibrin under the macula. Early hypo with late hyperfluorescence would be the differentiating on fluorescent angiography. So central serous retinopathy has varied clinical presentation and it's still an enigma with respect to its exact etiology. It is very important for the ophthalmologist to understand the spectrum of this disease and the diseases mimicking CSCR so that the appropriate treatment can be instituted of the patient. Low fluence PDT and subthreshold TTT are excellent treatment modalities. However, the cost burden to the patient should be an important treatment decision, especially in countries like us. And thank you for patient listening.